present you the differential diagnosis based on clinical presentation. I disclose not to have any conflict of interest related to this presentation, and I would like also to announce that all the figures were created by me, and I will be glad to share them or to share any slide with you. You will find my email at the last slide. Let's go to the cases. I will present you 3 cases, and this is the case number 1.
Hello to technician team, please could you confirm that everything is running well? Is everything okay?
I was on call and one colleague from
I'm just double checking with our admin if the sound is going good, but it looks like everything is well.
Okay, thank you.
I wasn't an expert about anosmia, so what I did was...
Yeah. Oslo, the sound in our room is great. Our admin just checked it.
Surprisingly, I found that in a preprint server, just one day before, a group of researchers from Wuhan published the first series of patients with neurological manifestations, and 2 out of 214 patients had anosmia, so the frequency in that study was not that huge. I also checked what happened with the Middle East respiratory syndrome and the severe acute respiratory syndrome, and I found only one single case published in Acta Neurologica Taiwanica in 2006. So what I told my colleague was, hey man, I think you should ask ENT because it doesn't seem to be very neurological thing. To have an overview about what happened with the coronavirus in Spain, the first cases occurred in the islands, in Canary Islands, or in Mallorca, in German, British, and Italian tourists. But by February 26th, there were already 10 cases in Spain. But what happened in Valladolid? Did we already have any case? First of all, I have to introduce you a little bit about the region where I work, which is called Castilla y León. Castilla is the region who gives the name to our Spanish language, which is also named Castellano. And it's a very well-known region for very good wines and also jamón ibérico, the Spanish ham, which is really excellent. I would love to invite you soon to Spain if all this coronavirus thing improves. To put the region in context, it is a very large region with an area which is higher than Austria, Switzerland, or Denmark. But if you consider the population, it is half the population of Denmark, and it's like about 3, almost 4 times smaller or less populated than Austria or Switzerland. So that should be also taken into account. Valladolid is the most populated city from the region, and it's located right in the middle. It is around 1 to 2 hours by train or by car to Madrid, which is right in the middle of Spain. By February 26th, there were 0 confirmed cases in our hospital. But what happened 1 month later? After 1 month, there were already 302 confirmed cases, and I guess that you are very familiarized with this type of exponential curves by this time. We tracked, and in every confirmed case, we ask the patients about the date when they started to be symptomatic. Only in those patients that were confirmed, probably the number of cases is much higher. And if you analyze specifically what happened by that time on February, the last week of February, we find that there were already people who were symptomatic. So probably what I was consulted for was another coronavirus case. After that, we included the anosmia in the COVID-19 symptom checklist from our emergency department. So if a patient declares to have anosmia, the patient is treated with special protections and goes directly to the area of coronavirus patients. Also, the Spanish Society of Neurology created recommendations to the Spanish Ministry of Health to include anosmia as a typical COVID-19 symptom and to recommend the patients with sudden anosmia to contact to their physicians. But, well, this lecture is about differential diagnosis of anosmia, and there are a number of reasons of disorders that can cause anosmia, as congenital disorders, post-traumatic, neurodegenerative, idiopathic, and from the infective point of view, it can be caused by synonasal disorders and also in post-viral infectious anosmia, including rhinovirus, picornavirus. Also, the other coronaviruses are also important, but given this differential, something which is critical is the pretest probability. By this time that we are living right now, the most likely explanation for anosmia seems to be the coronavirus. And probably you know many people who suffer the disease, something that many of our colleagues or relatives ask is about the prognosis. We don't know yet about what happens with the coronavirus anosmia, but in the case of other viruses, after 1 year, 85% of the patients have improved and 31.7% has completely restored the olfactory function. Surprisingly, it was found that prognosis in females is substantially better. So the question for this case that we can set the discussion is, should we create the specialty of neuronasology also, or it should be part of otology, infectious diseases? No, man, that should be ENT doctor's business, or it should be part of general neurology, as many other rare diseases. Let's move to the second case. And this case is about headache. This is a 58-year-old woman with prior medical history of type 1 carrier disease that underwent suboccipital craniectomy, and 2 weeks after the surgery, she described a new onset headache. This headache was a very intense headache, 10 out of 10 intensity, which occurred within 2 to 5 times per day. It was very brief, between 1 and 3 seconds, and the patient declared to be pain-free the rest of the time. During the episodes, or before or after the episodes, the patient didn't complain about cranial autonomic symptoms or hypersensitivity to stimuli, or nausea, or vomiting, or any other symptoms. So the question for this case is, what's the name of this headache syndrome? It's a rare headache type. Could we say that it is acute headache attributed to craniotomy? Should we classify it as a new daily persistent headache? Is it an epicrania fugax headache? It's a linear headache, or is it a headache attributed to septic non-infectious meningitis? All of them are included into the international classification of headache disorders, except for the linear headache, which is not very recently described in 2014, or the epicrania fugax, which was in the appendix. What we did with this patient was an MRI, of course. In the MRI, we found that in the T1 there was a hypo-intense lesion into the right cerebellar hemisphere that, after the administration of contrast, exhibited a ring pattern enhancement. In the sagittal views, we can see here the anatomical relationship of the lesion with a cavity post-surgical region, and as the lesion was enhanced by contrast, and the patient complained about this novel headache, despite the headache was atypical. The treatment was antibiotics, including meropenem, vancomycin, and ceftriaxone, and the patient underwent surgical drainage. We took 5 cultures, and all of them were negative. I have to admit that the patient was already treated when we took them, and the headache disappeared after the surgery. It is well known that headache can be in the pathophysiology, can be present in many different neuroinfections. The pathophysiology of headache is varied. It can be caused by meningitis, caused by the pathogen itself, or it can be also produced by the cytosine storm. It can be in certain pathogens, be caused by vasculitis, thrombophlebitis, abscesses, as we saw in this case, and also very importantly by abnormalities in cerebrospinal fluid pressure that should be determined in every patient after ruling out to have a space-occupying lesion. Every time we have a headache patient with red flags, we should consider the possibility of a secondary headache or even a high-risk secondary headache. Therefore, we should start the study if it's in the emergency department with a CT scan, or if it's possible with an MRI. And in case that the CT turns normal, you should consider to complete the study with angio, LP, or doing a venogram as well. So the important message is that the brain abscess can be present with headache, also with fever, nausea, vomiting caused by the rise in intracranial pressure. It can cause visual disturbances, also by the papilledema or the 6th cranial nerve palsy. It can cause focal symptoms, although that's not very frequent, or impaired level of consciousness. It is called one of the mimickers as well. But if you have a new onset headache right now, as we said previously, the pretest probability is very important. You should know that 1 out of 5 patients with coronavirus disease complains about headache. In our series here in Valladolid, it's almost 24% of all the patients describe to have headache. And the last case is case number 3. This case is much simpler. It is a 39-year-old man who complained about isolated myalgia and fever. By the person of fever, an infectious disorder was suspected. The differential diagnosis of infective myositis includes viral, bacterial, parasitic, and protozoan infections. Bacterials are not very common. It can be caused by a pyogenic abscess into the muscle. The main pathogens are Staphylococcus aureus, and it's usually related with surgical or traumatic injuries. With regard to the viruses, besides the coronavirus, many other viruses can cause myalgia, including the parvovirus, polyomavirus, adenovirus, influenza, which was the most frequent previously, Epstein-Barr, and many others. So in the diagnosis, sometimes it can be helpful to conduct a panel to find which can be the cause, unless you have a very specific suspicion. Concerning the parasitic cause of myalgias, many other agents, including protozoas like Toxoplasma gondii or Trypanosomiasis, both the brucei and the Chagas disease can affect the muscle. Also malaria, which is highly prevalent in certain areas of the world. Trichinella, rare pathogens like Dracontiasis, or cystodes, including the cysticercosis and hydatidosis. Cysticercosis is also highly prevalent in regions like South America or Central America, and should be always be considered into the differential diagnosis. So, the question to vote: which is your choice this time? Do you think that again we will be facing a case of coronavirus disease? It can be a sarcoidosis, influenza, dengue, or malaria? Well, in this case, something which is very important, as we have discussed during the whole presentation, is about the setting. This case was seen in Cameroon in 2017. It was, as we said, a 39-year-old patient which complained about generalized myalgia. And given the epidemiological context, the highest pretest probability was for malaria, but you should also consider dengue. So we tested for both, and it was positive for Plasmodium falciparum, and the patient was diagnosed of malaria and treated. So the take-home messages from this lecture are that infections can produce almost every neurological symptom, and they should be always present into the differential diagnosis. In the case of COVID disease, we will have to pay attention not only because of the acute manifestations of the disease, also about the post-infective disorders that could appear related to them. Also, the second take-home message is that the differential diagnosis of neurological infections requires a complete and detailed history. And last but not least, the pretest probability, it should be put in the context, the epidemiological setting, and it changes the way in which patients should be managed. So thank you very much. Here you can find my email address, and I will be happy to take some questions. Thank you very much.
Many thanks, David, for your interesting talk. We are waiting for some questions and comments for the audience. In the meantime, I would like to ask you a question regarding the main symptoms in central nervous system infections. We know that headache is quite common in meningitis, encephalitis, and even in, as you said, in COVID-19. However, as the prevalence of primary headache disorders like migraine is huge, I would like to ask you, is there any clues to distinguish the headache associated with meningitis and encephalitis in comparison with the classical presentations of migraines or other primary headache disorders? In your view, how is the behavior of the headaches in ear infection and in meningitis or encephalitis? What are the clues to suspect this in a person with headache?
Morning, Professor Carol. Good morning, everyone. Welcome to this Congress. Thank you for the question. And that's a very interesting question, given that the prevalence of primary headache disorders is particularly high. In the case of migraine, around 13% of the population suffer from that. The International Classification of Headache Disorders establishes that if the headache is a new onset headache, or in those cases with a pre-existing headache, patients describe a significant change, either in frequency or in the phenotype of the headache. That might be the crucial point. But I think that in the infectious disease field, a very important take-home message is that if you are considering the possibility of a central nervous system infection, you are obligated to rule that out. You have to do some tests because the risks for patients' lives are too high to fail the diagnosis.
Many thanks. Are there any comments or questions for the audience? I see that some people are attending from Brazil. There are 3 a.m. in the morning there. So, bom dia ao pessoal do Brasil que está escutando hoje a reunião.
Bom dia, é prazer para nossos amigos brasileiros.
If there are no other questions, then I would like to ask you regarding the case that you presented with muscle pain. Again, are there any clues to distinguish myalgia or muscle pain associated with viral infections from other common conditions like fibromyalgia or polymyositis? It's true that in many viral infections, including COVID-19 or dengue, we have the history of dengue, for example, initially was classified as transient muscle dysfunction. And then there was discovered as a group of people having polymyositis associated with the viral infection. So what do you think regarding the pattern of muscle pain? Will be only a pure symptom, or could be a direct inflammation and infiltration, or even something more serious that we should take a look in the context of the infection?
In these viral infections, something which can be helpful is that during the viremia, or during the replication of the virus, there is a generalized inflammation state, and that causes that usually the symptoms in these viral infections are quite generalized across the whole body, instead in contrast with other primary muscular disorders in which pain may be more localized. And also, of course, they are usually accompanied with other typical symptoms that may put the suspicion of infection in context. It is true that the fever is not always present, but for example, headache is a very common symptom. And in those muscular conditions, as you mentioned, you don't usually have a headache unless a pre-existent primary headache disorder. And it's also the pathochronia of the disorder, where you can suffer from all the onset of the symptoms is typically very abrupt. It may be the onset of a muscular condition, but that's something also that should be taken into consideration.
I see a brief question here asking, what is the experience on the use of ADA as a marker of infection in cerebrospinal fluid?
Which biomarker? Sorry, I cannot see the question.
ADA. ADA.
Mm-hmm.
The amino acid.
Yeah, well, that's one of the $1 million questions. I think that there is not yet a perfect biomarker of CSF, of infections in the CSF. Even you should be very aware about the moment when the CSF determination is taken, because sometimes we assume that a normal sample equals no infection, and if you take it very early over the course of the disease, sometimes you may get a false negative result, or if the processing of the sample is not adequate. But you need to put all the information you got, clinical and preclinical, in context.
Two more brief questions with a brief response needed. Regarding the anosmia associated with coronavirus, there is any particular stage of the disease in which the symptoms present? And the second question is, should we perform CT scan of the brain with contrast first before doing lumbar puncture?
To the first question, the answer is it seems to be very early in most of the cases. We reviewed that, and many patients describe it even as the first or the sole symptom. And with regards to the second question, you may be sure that there is no risk of intracranial process that may complicate the lumbar puncture. So if is there any focal symptom, decreased level of consciousness, if the patient has a papilledema, in all those cases, you may do an imaging exam before doing the lumbar puncture. But otherwise, if the fundoscopy is clearly normal and the suspicion for an intracranial space occupying lesion that may endanger the risk of creating a gradient is low, then you can do the LP without waiting further for the CT or imaging examination.
Okay, thank you so much. I think we have many questions to be answered through the chat. However, because of question of time, now we'll be giving time to the second presentation. Many thanks for your talk.